Good morning, ladies and gentlemen. Today I shall be talking on bronchoscopy in liver ICU, and I will be covering the topic under the following headings. Pulmonologists, two of us are here, Dr. Arvind and me, are frequently called upon to perform bronchoscopy on critically ill patients in liver ICU, and the ease and safety and portability of bronchoscope make it one of the most commonly sought invasive procedures in liver ICU. It was in the year 1967 when the Japanese bronchologist Dr. Shigedo Ikeda he pioneered the bronchoscope, and subsequently in 1970s and 80s he did more improvement in the optics of the scope, and what bronchoscope we use now is the latest version of what Dr. Shigedo Ikeda manufactured with the help of Japanese Olympus company. Coming to the indications of bronchoscopy in liver ICU, one of the commonest indications is removal of the mucus plug and atelectasis, and the second most common is to get the samples of bronchoalveolar lavage in cases of ventilator-associated pneumonia, as well as in cases of unexplained infiltrates in chest X-ray as well as in CT chest. And also it helps in identifying the site of bleeding in the airways. And my intensivist colleagues will agree that it does help in difficult intubation cases, as well as percutaneous tracheostomy guidance when you are putting the tracheostomy tube, and very uncommonly removal of foreign body. Contraindications to bronchoscopy, the most important thing to keep in mind is severe hypoxemia. When the PaO2 is less than 60 or SpO2 is less than 90% with 100% oxygen, then it is one of the absolute contraindications. The reason being, when we put the bronchoscope inside, so the trachea, through that it is going, so ventilation is getting affected, and over and above that, when we put saline through the scope for taking bronchoalveolar lavage, there is further desaturation. So if a patient is already compromised with 100% of oxygen, then if there is further deterioration in PaO2 to 40 or 30, it may be extremely difficult even to save the patient. So this is an extremely important thing to remember. Other than the other contraindications include acute coronary syndrome or severe hemodynamic instability, and if there is very significant increased intracranial pressure or respiratory rate more than 30 with the use of accessory muscles of respiration, and if the patient is already not intubated, in that case, if the patient has significant altered mental status, because it may give rise to aspiration pneumonia. Now coming to the preparation, well, in any invasive test, what we do before doing it, you have to take a consent. So in the same way, in consent, what we do? We explain to the patient as well as the relatives what are the indications of the procedure, how we are going to do the procedure. We should tell in details, and of course the potential complications as well to be discussed with the patients. The most important thing to remember, this is more for the hepatology residents who work day and night in liver ICU, that in a non-intubated patient, if you are asking for a bronchoscopy to done, the very important thing is that you discuss with the patient and more so with the relatives that while doing the bronchoscopy and taking lavage during the procedure or after the procedure, the patient may require to be intubated and put on mechanical ventilator. And you should take a written consent, because subsequently there might be complaint from the relatives as well as you might face a litigation. So after taking the informed consent, and secondly, when you do a bronchoscopy, preferably the patient should be in empty stomach, so nothing should be given 2 hours prior to the procedure. Or if the patient is intubated and recently feed has been given, then you can aspirate the food particles inside the stomach, and after that do this procedure. Safety checklist and monitoring, like any other invasive test, we must follow the Hippocratic Oath. What did the great physicians taught us? That do not do any harm to the patient. So any invasive procedure we do, ideally we should be very sure that the benefit to the patient is more than harm to the patient. And no other procedure, this principle of Hippocrates to be followed than doing a bronchoscopy in liver ICU. And the patient, of course, in any invasive procedure, patient continue to be on cardiac, blood pressure, as well as SpO2 monitoring. And bronchoscopy with the BAL is associated with, as I described in one of the previous slides, with the PaO2 and FiO2 ratio is false. And because of this, what we do is we go to the ICU, and before we start the procedure, FiO2 we increase to 100%, and this is given for 5 to 15 minutes. This is called hyperoxygenation. And when we doing the bronchoscopy, then frequently after we put the scope and we put saline for taking lavage, then many a times or most of the times there is a fall in saturation. So the intensivist is there, and till it comes to 88% or below, we immediately remove the scope, and patient continue to be on 100% oxygen. And while we are waiting for the SpO2 to rise to 95% or above, what we do is we clean the external surface of the scope, and we do suction and clean the internal channel as well. Coming to the sedation or topical anesthesia, if the patient is intubated, in that case, things are simple. The intensivist asks the nurse that you increase the dose of the sedative, and in non-invasive patients, we give a cocktail of midazolam, fentanyl, or propofol in different combinations depending on the situation as well as the body weight of the patient. Coming to the topical anesthesia, obviously lignocaine is used, and we use different ways. One is we give the injection just below the thyroid cartilage, or we can give a nebulization with 2% lignocaine, or we can give the spray to paralyze the vocal cords. Usually we combine the nebulization or this injection over here along with the spray. And then we put the scope through either the oral cavity or through the endotracheal tube or the tracheostomy tube, whatever the situation is. And while we visualize the vocal cord, again we put one spray of through the bronchoscope, the outer channel, we inject lignocaine, and then we go inside the trachea, and again we put injection of lignocaine. Why? This is to prevent the cough reflex so that the procedure becomes comfortable for the patient, as well as the optics of the scope remains clear. Now, bronchoscopy in an intubated patient. One thing to remember is the scope, the diagnostic adult scope, what we have or what is conventionally available in the commercially, the outer diameter is 6 millimeter, and the difference between the outer diameter of the bronchoscope and the inner diameter of endotracheal tube should be 2 millimeter at least, or up to 1.5 millimeter is okay. If it is not that, in that scenario, you may damage to the outer sheath of the costly bronchoscope. So then one may ask, why don't you use a pediatric bronchoscope or the neonatal bronchoscope, which are as well available? The problem is that because the smaller suction channel of the pediatric or neonatal the bronchoscopes, there is less suctioning capability, and you cannot visualize properly, and the procedure is inadequate and unsatisfactory. Now, coming to the safety of bronchoscopy in ICU, if an experienced person is doing the scope and taking appropriate precautions, as we discussed earlier, the FOP is pretty safe even in ARDS patients with PaO2 by FiO2 less than 200. And as we discussed, with the after we put the lavage fluid, the SpO2 falls, but it usually recovers within 5 to 15 minutes, and there is no long-term sequelae to this problem. And the ICU, in liver ICU patients, even patients, most of the patients, or rather all the patients, are on inotropic support, and with that also we do a bronchoscopy, and rarely we require to increase the dose of inotrope. Now, coming to the complications, in a safe hand, it's pretty safe. Like in this study, we can see that desaturation they found only in 3.4% of the cases, and our study probably is similar. And other complications may be hypotension or arrhythmias, particularly if you are not judiciously using lignocaine. The therapeutic dose of lignocaine is up to 300 milligrams, so you should be careful that you do not give more lignocaine and there is complication to the patients. Now, another thing, just for mentioning, pneumothorax. Pneumothorax with a bronchoscopy and lavage is usually extremely uncommon, and it occurs more when you are taking transbronchial lung biopsy during the procedure. This usually we do not do in liver ICU. The reason being most of the patients are on anticoagulants. So if we take transbronchial biopsy, in that scenario, there could be torrential bleed and we may not be able to save the patient. So when this then transbronchial lung biopsy is done, it is done in patients like with other solid organ transplantation like kidney transplantation or bone marrow transplant cases, or people with HIV/AIDS who have where we are suspecting there is some uncommon organisms like pneumocystis zero-BC or something like that. There the yield of bronchoalveolar lavage is not as good, and if you take a biopsy and then histopathological examination, the yield increases. So as I said, that appropriately selected case, ICU bronchoscopy is a pretty safe procedure. So how commonly bronchoscopy is performed in other ICUs? Well, I could get two retrospective data in this study where they evaluated the data of more than 52,000 patients, and there the 1,800 patients underwent bronchoscopy. So this is coming to 3.7% patients who underwent bronchoscopy. In another retrospective study, which included more than 60 lakh patients, their data was evaluated from the year 2012 to 2018. And what they found was interesting thing that from 2018 over a period till from 2012 to 2018, there had been exponentially increase in bronchoscopy from 9.5 to 10.8%. And the authors as well as the editor felt that United States, this study is from United States, that probably in some cases the bronchoscopy is being done excessively, and they said that one should limit the things to reduce the cost of healthcare in that country. Now coming to the therapeutic aspiration of secretions, this is one of the most common indications for which we do bronchoscopy in liver ICU. This kind of a X-ray is not very uncommon, and the two common differential diagnoses of this condition is, of course, one is some thick mucus plug blocking the right main bronchus and causing the collapse of the right lung, or there could be pleural effusion. So diagnosis even clinically may not be that difficult, because see here the trachea is deviated to the same side, whereas we during our MBBS we have studied that in case of pleural effusion the trachea will be shifted to the other side or it will be centrally placed. And secondly, now all the ICUs have ultrasound. So if we put an ultrasound probe over here, in case of pleural effusion you will find fluid, and in case of collapse there will be B lines. So how now what should you do? You have an X-ray like that and the patient's saturation is falling. If the saturation is falling to critical level, obviously immediately you will have to do a bronchoscopy. But if not so, then ideally you should put the patient in lateral decubitus, and the affected side, in this case the right side, should be up. Well, and after that you give good physiotherapy, give good chest percussion so that the secretions come up to the level of trachea, and then you continue suctioning. Fine. After that, repeat a chest X-ray. If the thing has cleared, then fine, you are happy, the patient should improve. But still, if this opacity doesn't disappear and the collapse of the lung persists, then the bronchoscopist is requested to come over, and what we do, we put the bronchoscope through either through that endotracheal tube or the tracheostomy tube, and usually this kind of a thing we see, the thick tenacious secretions, in this case in the right main bronchus. So if we try to suck it, it will not usually come. So what we do is we instill saline or sodium bicarb or N-acetylcysteine solution, and usually it gets dissolved, and gradually we can suck out the thing. After that, after we have removed, like in this case, we have removed the things, then we go gradually, systematically, we come to the upper lobe, we see all the three segments of the upper lobe, then come to the middle lobe, the medial and lateral segments we examine, and then go to the lower lobe, and all five segments of the lower lobe we see. If we find there is further secretions down below, then again we put saline and we aspirate the thing, and if blood is there, that also is sucked, and then we see how is the anatomy of the tracheobronchial tree on that side, in this case on the right side, and if it is okay, then we are happy, and then we come back to the carina and go to the other side, like we go to the left side and again visualize the thing in the similar way. So Coming to the next very important indication, the ventilator-associated pneumonia. Like this X-ray or this CT scan in liver ICU or any ICU is not very uncommon. And if this develops within the period of 48 hours after the patient has been intubated and put on ventilator, yes, this is ventilator-associated pneumonia. And what we do is, again, similarly, we put the bronchoscope and go to the affected segment. And we wedge the scope with the tracheobronchial tree and then instill saline with the 20 ml syringe, and the saline is sucked back. When we suck it back, then the cells from this area as well as the bacteria and the other organisms are sucked out, and then this is sent to the lab for the microbiological examination. What all specimen we send for? We send for bacterial examination, gram stain, aerobic culture, and biopha. For the fungus, we send for fungal stain as well as for fungal culture and galactomannan. That's another important test. Galactomannan, if you are just sending minimal, the yield is not that good, but galactomannan in bronchoalveolar lavage, the results are pretty good, and you can confirm that it's a fungal infection, or you can upgrade the antibiotic. Like if a patient is on some fluconazole or something, then you can upgrade to amphotericin B. Now, what is the diagnostic yield of bronchoscopy? This is a meta-analysis published in Journal of Thoracic Disease in the year 2021, and as per this, the yield varied from 13 to 59%. And this yield improves further if you do the transbronchial lung biopsy, where they found that in one of the studies it went up to 74%. But as I told earlier, that routinely we are not doing transbronchial lung biopsy because there could be torrential bleed and we may lose the patient. Though this is another study where they diagnosed, BAL was diagnostic in 61.9% cases, out of which bacterial infection was 26.3%, fungus was in 16.1%, and virus in 11% of the cases. Now, another question one may ask, does bronchoscopy improve the survival? Well, to find out that, I found two studies. This is one of the studies where they evaluate the data of around 9,000 patients. Out of that, 783 patients underwent early bronchoscopy. Early means within the 24 hours since the patient has been put on ventilator. And the other group did not have early bronchoscopy, means they underwent bronchoscopy after 24 hours. And they did not find any mortality benefit in these patients in the first 24 hours, or in-hospital mortality, or 90-day mortality. And the interesting finding over here was that early bronchoscopy prolonged the ICU stay, hospital stay, as well as the patients was less likely to be discharged to home, which was statistically significant. So the reason probably is that the patients who are more severe because of the disease process, because of that they underwent bronchoscopy, and that's why this particular data is there. Now, this is another study where they evaluated the data of around 2,000 patients. Out of that, 200 plus patients underwent bronchoscopy, and the other group did not undergo a bronchoscopy. And here what they found is that there is significant significant survival in the patients. They found that this Kaplan-Meier's curve shows that the patients who underwent bronchoscopy, there was significantly higher survival than the other group. So these two studies show that there is a divided opinion whether the bronchoscopy is useful in patients in ICU or liver ICU. So maybe the reason is the data has come from different sets of patients. There are different physicians who are treating, so that might be one of the reasons. Now, coming to how bronchoscopy helps in ICU patients. Well, we understand that the patients who are in ICU, who are critically ill, they have inability to expectorate their sputum, and because of that, the respiratory secretions get blocked in the trachea. And because of this, the large number of inflammatory factors or secretions get lodged in the tracheobronchial tree, giving rise to systemic inflammation. The advantage of bronchoscopy is that we put it through the trachea and it goes deep inside the tracheobronchial tube, both sides, and because of that we can suck out the inspissated sputum and the respiratory secretions, and with that the inflammatory mediators lodged inside, they are also removed, and because of that obviously the patient's ventilation improves and the patient general condition improves. And another advantage, as we discussed earlier, that we take bronchoalveolar lavage from the affected segment, and that helps in early identification of causative organisms, and we get early sensitivity pattern, and that helps the clinician to de-escalate the antibiotics, prevent the complications or side effects of the other antibiotics which is not required, and that causes shortening of the hospital stay of the patients. Now coming to the aspiration pneumonia, we know that aspiration pneumonia was not very uncommon in ICU, that include the liver ICU as well. What happens is the patient's gastric contents come to the lung, and as we know the anatomy which we studied in first or second year of MBBS, that the right main bronchus is almost in direct continuity to the trachea. So the gastric content which comes through the trachea, it goes and gets lodged to the right side, and left main bronchus is usually oblique and it is narrowed, so usually it goes to the right side. Now obviously the common sense says that if the patient is aspirated, as early as possible you should put a bronchoscope, you aspirate and remove the gastric content as well as the other inflammatory markers. And does it help? Does early bronchoscopy help in survival of the patients? Well, this study what they did, 93 patients, they underwent early bronchoscopy, while as 61 patients underwent late bronchoscopy. And what are the results? This Kaplan-Meier curve shows that definitely in early bronchoscopy there is a survival benefit, and this is statistically significant. There was another study. This is a study from Turkey. It has been published in India Journal of Critical Care Medicine in 2021. What they did is they randomized 76 patients. In one group, there is 38 patients who underwent bronchoscopy in the first 24 hours, and the second group, they received standard care, and there was no bronchoscopy was done. And what did they find? They found that early bronchoscopy group showed reduction in ICU mortality and ICU length of stay, but this was not statistically significant. Well, another advantage of early bronchoscopy in aspiration pneumonia is that you could get the right, normally as I told, the gastric contents get lodged in the right lung, right lower lobe. So by doing an early bronchoscopy, you are able to detect the organisms and immediately start the appropriate antibiotics. Okay, now coming to the other indications of bronchoscopy in liver ICU, one indication is difficult intubation. Difficult intubation if the patient is extremely obese, having severe obesity hyperventilation syndrome, or there is some neck deformity or some injury, or mandible is deformed. In that scenario, it becomes very difficult to see the vocal cords by direct laryngoscopy. So that time the help of bronchoscope is taken. What is done is that bronchoscope is put through the endotracheal tube, and the scope is kept just ahead of the opening of the endotracheal tube, and both the thing together it put through the mouth. And after that, what is done is after illuminating the bronchoscope, under the light the vocal cord is visualized, and both the things together are put inside the trachea. And after it has been ensured that this endotracheal tube is in the appropriate place in the trachea, the bronchoscope is gradually removed and the endotracheal tube is placed there. So for helping doing the intubation, most of the OTs, including our OT, has a intubating bronchoscope, and some of the ICUs also have intubating bronchoscopes. The other uses of bronchoscopy include percutaneous tracheostomy. What is done is, here the incision is given between the second and third cricoid cartilage. So it is done better under vision. So the bronchoscope is passed inside, and just above the second cricoid cartilage it is kept, it is illuminated, and under vision then the incision is given over here, the dissection is done, and then safely you put the tracheostomy tube. And after it has been placed properly, just you remove the bronchoscope. And another indication, very uncommon indication, is foreign body. In some of the hospital appliances, particularly tracheal appliances, can rarely find their way into the trachea. So one such case we found, both Dr. Arvind and me, last year. So one patient was there in the ICU isolation. He had collapse of one lobe, and when we did bronchoscope, we sucked it, and afterwards we found this foreign body. And every time we caught the foreign body with the forceps, and then whenever we are bringing the scope as well as this foreign body through the forceps, it gets stuck in the tracheostomy tube. We repeatedly tried and were unable to take it out. Then what to do? We found that the patient is desaturating, so we didn't want to play with the life, because as we discussed at the very beginning, when you do an invasive thing, you must remember Hippocratic oath, no harm to the patient. So to do no harm to the patient, when we ensured, yes, it is lodged safely in the right main bronchus, we came out and we thought, okay, let's discuss and think what to do. So that this case was discussed the next day in the third floor here. And Dr. Sarin sir kindly told us that we should discuss this case with Dr. Tempe, and we did the same thing. And Tempe sir said, why don't you take out the tracheostomy tube and with that take out the bronchoscope as well as the foreign body. We said, well, let's try. So with the help of Dr. Prasant and both Dr. Arvind and me, we tried that. We went inside, caught this foreign body with the forceps, and when we came near to the tracheostomy tube, Dr. Prasant removed the tracheostomy tube, and immediately after that we came out with the bronchoscope and the foreign body. And fine. And after that, immediately Dr. Prasant intubated the patient, so the foreign body was removed and the patient was comfortable as well. Now coming to the future directions, well, we all know that this robotic surgery is pretty common, and the more popular one is the Da Vinci robotics. Similar way in bronchoscope, the AI co-pilot bronchoscope robo is available. How it is helping? Here is the operator, and here is the patient, and the assistant will be here, and assistant will be putting the scope through this, and there will be AI robo. So AI robo, what it will do? Normal bronchoscope, I said, the outer diameter is only 6 millimeters. So we can go up to the second or third generation of tracheobronchial tree. Here the robo will go up to fifth or sixth generation thing, and so this will improve the yield, because the affected area it will identify by the AI, and so it will go to that area and suck the secretion. So it will be safe for the patient, as well the yield will be more. But it's still in the research tool, and maybe later on we are going to get this. Another interesting thing is that we all know that there was an AI training summit in healthcare in this very auditorium on 7th of December 2024. Before that, I knew that AI is going to change everything, but I didn't know much how AI can help me in gaining knowledge. So they did very nicely teaching over here, and subsequently every week they are available on webinar. So I tried to learn from them. And then I thought, well, if I want to see what is the future of bronchoscopy in ICU, let me ask this health buddy co-pilot. So I uploaded, at the thought, I uploaded a few articles in that, and then I gave this prompt to the software that read the articles uploaded here, and also read other articles available in the internet on AI in ICU bronchoscopy, and write in details as to how AI is going to help in ICU bronchoscopy in future, and you give the relevant references as well. Well, I got this answer, and the improved diagnostic accuracy, risk prediction, personalized treatment plan, and workflow optimization. And it gave 3 references as well. Initially, I thought that maybe AI hallucination, but when I checked, no, they are real references. So AI, we understand that is going to be a game changer. It will help in ICU bronchoscopy as well. I'm not going into the details of that. And coming to the ILBS data, well, during the period of last 7 years, from January 2018 to December 2024, we did a total of 249 bronchoscopies. Out of that, 216 or 86.7% were males and 33 or 13.3 were females. And as I discussed in one of the earlier slides, that the sample sent, bronchoalveolar lavage sample sent were for gram stain, aerobic culture, bacterial PCR, AB smear, fungal stain, fungal culture, and galactomannan. So at least one of them were positive in 51.8% of the patients, and 2 samples were positive in 9.2% of the patients, whereas 0.9% patients, none of the samples were positive. And the organisms grown in aerobic culture included Escherichia coli, Elizabeth Kingia meningococcia, and of course the other organisms also was seen. So, ladies and gentlemen, to come to the conclusion, diagnostic or therapeutic bronchoscopy is an important tool for efficient management of liver ICU patients. The combined ability of direct visualization and sample acquisition makes it very useful in the diagnosis and management of respiratory problems in the ICU. In critically ill patients, bronchoscopy is a safe tool and provided it is appropriately applied. And bronchoscopy patients with hypoxic respiratory failure carries an increased risk, and risk and benefit should be thoroughly assessed before proceeding with bronchoscopy. Thank you.